Thank you. Welcome everybody to this year's Eye News Symposium. I'm delighted to see you all here. We've got a really good range of lectures and lecturers. Our first speaker, Professor Liu, I first met when he was examining me for my MD thesis. So this takes us back quite, it's the second time we met. And he's well known. He's a pioneer in the field of cornea, especially in keratoprostheses. And this is an interesting talk because sometimes big changes, I think, in ophthalmology don't necessarily come from very clever inventions or biochemistry or from genetics. Sometimes the big changes and the things that make a big influence and the things that have the highest impact on patients are relatively simple ideas but expressed well. And so I'm delighted for Professor Liu to be talking today about the pros and cons of sequential bilateral cataract surgery. Thank you.
Thank you. Well, good morning, everybody, and thank you for spending your Sunday here listening to us to this talk. I'll try and keep it interesting for you. Firstly, I want to find out who's practicing and advocating bilateral same-day cataract surgery at the moment. One. You see, actually, this is quite a rare phenomenon, and for those of us who are proponents of bilateral cataract surgery, sometimes we can be ostracized. So I will tell you the statistics and the science behind it, and then you can judge for yourself how you want to apply this in your own practice. So hopefully, after the next 40 minutes, you'll have a much better understanding of bilateral cataract surgery. So I am a proponent of safe, informed, immediately sequential bilateral cataract surgery, and Eye News has paid for my travel and accommodation, and also they said they would support my promotion to become a knight. So I'm very grateful. very grateful to them. And anyway, you know this magazine. It's really quite wonderful, and it's always current and topical. And you can see, if you turn to this page here, you can see this young man here, and I did examine him for his Doctor of Medicine thesis of the Oxford University. He's forever young, isn't he? Anyway, thanks very much for this. Next slide, please. So a historical note. I think as ophthalmologists, we've always been taught to operate one eye at a time. And the reason for that is because we're so frightened of causing blindness in both eyes, which remains a possibility, but cataract surgery nowadays is really a lot safer. So if you look at traditionally what kind of cases we'd be looking to do bilateral same-day surgery, we're looking at cases which require general anesthesia, especially high-risk anesthesia, so we don't put them through 2 GAs. And also for cases when the visual potential is unknown in either eye because, for example, the cataracts are so dense that you can't actually see what the macular optic disc looks like. Next, please. Now, there is a very deep fear, which you feel in yourself that, even when I do it, that I know that one day somebody might go blind in both eyes as a result of my practice. But it's mostly irrational fear, and I'll explain to you why it's irrational. Now, the fear can be transferred. So let's say if I and my patients agreed to do immediately sequential bilateral cataract surgery, somewhere along the line when they finally appear on the operating list on the day, they may have changed their minds. And if I ask them, sometimes it could be a family member, or it could even be one of the ward nurses who frightened them, and then they chicken out. However, look, there are many other eye surgery that we do both eyes at the same time, and they all have sight-threatening complications. So why is cataract surgery different? Next, please. Now, the climate is changing, and if you look at the NICE guidance on adult cataract surgery, there are 2 subsections that you can be looking at. So firstly, next slide, 163. It says, consider bilateral simultaneous cataract surgery for. Firstly, I must take issue with this nomenclature because it's not simultaneous, it's one after the other. So it is actually sequential. Now they're saying people who are at low risk of ocular complications during and after surgery should be considered for bilateral same-day surgery. And also people need to have general anesthesia for cataract surgery, but for whom general anesthesia carries an increased risk of complications or distress. So for example, if you have a patient who's demented and you have to kind of catch them before you can put them to sleep to have surgery, it would be quite unkind to have to do that twice to them if you can rehabilitate them in one go. And often, actually, dementia improves when patients see better. Okay. 164. Discuss the potential risks and benefits of bilateral cataract surgery with people, which should include the potential of immediate visual improvements in both eyes. In other words, there is measurable advantage of doing both eyes at the same sitting. But they also say it will not be possible to choose a different implant based on the outcome of the first eye. Actually, that is not very important because with modern day biometry, they don't really get it wrong very much, very often at all. And in 50,000 cases done in America published, that there has been no case which required going back to readjust the biometry. We have to explain the complications, the risk of complications in both eyes during and after surgery that could cause long-term visual impairment. So here we're talking about endophthalmitis or internal infection of the eye and cystoid macular edema, which does not always completely recover. And also the likely need for additional supports because they are now recovering from both eyes rather than just one eye at a time. So here's the nice guidance. Next, please. Next, please. So this talk, we have 5 sections, and you can stop me anytime to ask questions. Firstly, we'll cover the rationale for immediately sequential bilateral cataract surgery, ISBCS, the prerequisites for offering this type of surgery, the measures that we can take to reduce risk, stakeholders' perspectives from the patient's point of view, from eye surgeon's point of view, optom's point of view, etc. And the ethical and medical legal aspects. Yes, please. So rationale. So these are 2 newer methods of delivery of cataract surgery. The one on the right, we're not really talking about, except that they self-prepare for surgery and they more or less go to theatre directly, bypassing the ward and day case units. And then they leave immediately afterwards. So they're just there for 40 minutes. This is what we're talking about, bilateral surgery, both eyes at the same admission, and there is a lot of convenience to patients and their relatives and carers. And it has been worked out that the second eye, including re-scrubbing, only adds 12 minutes to your operating time. So obviously there's reduced cost to hospital and society, and the question is whether it's safe. And we could be talking about the precautions, case selection, and of course patient choice as well. Next, please. We've already talked about this. However, of course, 2 wrongs don't make a right. Next, please. These are some of the advantages to the patient and the people looking after the patient, including ourselves. So one referral is made, and then the referral, when it comes to the hospital or to the GP, we process it the once rather than twice when they come for second eye surgery. 1 pre-assessment, 1 admission, and also when you do the second eye, because you've just done the first eye, you've actually learned about how the first eye behaves. For example, how the capsule behaves, or how the nucleus behaves, etc. You can apply that knowledge to the second eye. If you require a GA, then only 1 is required. 1 post-op visit, 1 lot of waiting for refractive stability, which can be up to 6 weeks for a corneal wound. 1 sight test, 1 pair of new glasses, and no period of binocular imbalance. Now, if you have a long waiting list, you could be waiting for months for your second eye, and that's really quite unkind, especially if there's any anisometropia. Say if you have a myope, if you convert it to become an emmetrope and the other eye is still very myopic. And of course, you can also save money. But the main thing is that it is actually a better method of delivery of cataract surgery is not about saving money, although that is the secondary consideration. Next, please. So what are the disadvantages? Well, you are taking a risk with both eyes at the same sitting. And also, there will be discomfort in both eyes during the recovery period. Next, please. Any questions up to this point? Please do ask something.
If you've got one eye where the vision is significantly down, the other eye is still reasonable, would you still consider that? Or is there, what sort of limit would you put on a good eye before you get the second cataract?
Okay, well, the guidance is also given in NICE in that your second eye surgery should have the same criteria for listing as your first eye. So if you've got a clear lens, then you wouldn't do it. If you've got a little cataract, then you wouldn't do it. It has to be visually significant.
Can I ask, do you go
Yes,
onto
of
the
course.
second eye? Is there a period where you reflect on how the first eye surgery went before you go into the second eye? Are there ever times when the surgeon decides, actually, I'm just going to do one, this is a bit tricky?
Yes,
Is
yes. We'll come on to that. Yeah. Okay, so now let's have a look at the prerequisites. Okay, there we go. Of course, we need bilaterally visually significant cataracts. Now, it may be that the milder cataract is not actually very bad, but you look at it and you know from your experience that after removing the worst cataract, you know that they will want the other eye done. You know from your experience, don't you, that the patient will tell you, oh, don't touch my good eye. And then you know that when they come back after the first eye, they say, well, now this is the good eye, and my good eye has become the bad eye, and I really don't like it. So even if it's a moderate cataract, you know from your experience that they will want second eye surgery. So you can list them for bilateral, if you like. The patient must have informed consent. It's actually quite difficult even to get informed consent for one eye, but getting informed consent for bilateral surgery is more difficult. You need to have reliable biometry. So nowadays we're looking at partial coherence interferometry, like the IOL Master. You need to have a good surgeon track record. You need to have that surgeon supported by an experienced and knowledgeable theatre team. And we can't have a new person in the team when this sort of surgery is done because you're just inviting disaster. You need to have a good hospital track record of endophthalmitis. You need to have day one follow-up at least by telephone, and there has to be a hospital hotline. If there are any problems at all, redness, pain, sensitivity to light, straight away they go back to the hospital to be looked at. Next, please. So obviously the equipment and instruments very important, maintenance and renewal of equipment, and theatre air conditioning and filtration. So your operating theatre needs to be in tip-top condition, and the microbiologists should be coming in to check the air quality on a regular basis. And don't chop and change machines and implants too frequently. You know, even these are just basic principles. Like if you're using the same implant for 3 to 5 years, then it's fine because there's initial learning curve, and then you get good results. Once you change to a new implant, a new injector, then the results immediately plummet for the first few months. Centralized sterilization, especially phaco probe. The phaco probe is the most difficult thing to sterilize because it's got a long lumen, and it's got to be done properly. And then increase the use of disposable instruments. Well, I mean, I do have some issue with this because it's not a very sustainable solution. And with the metallic ones, you're throwing away metal, and there's only so much metal in the earth, on Earth. So if you throw it away, then you're not going to be getting more metal. And if you throw away plastic, that's not very good either. So audit is very important. So we won't go through all the details, except that it's greatly enhanced by electronic patient or medical records, EPR, EMR. And there has been a national audit, the National Ophthalmic Dataset, but unfortunately, NOD is going to run out of money from August this year, and the ministers will not fund any more money. We're just trying to get some more
Can I
money.
ask you
Yes.
what you mean by corneal decompensation? I'm not sure what. Can you explain?
Corneal decompensation is when the cornea fails from, in these circumstances, from cataract surgery, that maybe you use too much phaco power or fluid, or you're not careful with your technique, then the endothelial cells either drop off or die, and the cornea swells, gives you corneal edema. And normally that doesn't really happen with careful surgery. However, there are pre-existing conditions like Fuchs endothelial dystrophy, which can predispose to corneal edema.
Thank you.
Okay. Okay, next. So the prerequisites. Any questions on prerequisites?
You did mention that doing one doesn't always occur if one eye's not got a sufficiently dense cataract. What we find in practice is that one might have had, say, a dominant eye,
Yeah.
has an operation on the non-dominant eye, that then sees better than his dominant eye, and that causes a lot of problems.
Yeah.
So I can see that that's a good idea to do sequential surgery, because they maintain the dominance.
That's right, yeah. Very, very true. Yeah, absolutely. Any other questions before we move on? Okay. So this is a very important part, what measures you can take to reduce risk. And there are basically 3 strategies. Okay. Firstly, there is the option not to proceed with the second eye if the first one has not gone completely well. So already you know that, therefore, it's not a ballistic decision that you would actually do both operations. You're planning to, but if that doesn't go well, you're not going to do that one. Okay, so that has to be explained to the patient as well. The second thing is to exclude high-risk eyes because you're more likely to go wrong. And the third thing is some delicate dance in the operating theatres to have 2 trolleys of instruments, and we'll go into the details of that. 2 trolleys for 2 operations. Next, please. So let's first look at the option not to proceed with the second eye. We all know that the risk of endophthalmitis is related to vitreous loss and the length of the operation. So therefore, if you've lost vitreous, then you shouldn't operate on the second eye. And similarly, if you've taken such a long time for your first operation, let's not put the patient through the second one. And similarly, for cystoid macular edema and retinal detachments, the risk of those happening also increased by vitreous loss. So if you have vitreous loss, that's just another reason for not proceeding with the second eye. These are the things which would put me off doing the second eye. Posterior capsular tear, zonular dehiscence, long operation, high phacoenergy, and any site of vitreous in the anterior chamber. So we've gone through that already. That's why it's immediately sequential and not bilateral simultaneous. And I don't know how that crept into nice terminology. Next, please. When excluding the high-risk eyes, so you're thinking of listing now, they've got bilateral cataracts, but these are the things which might put you off. At least you have to discuss with them. Now, blepharitis can be treated with lid hygiene and chlorphenicol ointment at bedtime for 1 month. Blocked tear ducts, that especially if there's a mucocele that really needs to be sorted out, even for unilateral cataract surgery, let alone bilateral cataract surgery. Diabetics, especially if they have any diabetic retinopathy at all, we don't want to take that risk because we know that if there is diabetic macular edema, you do the operation and it can suddenly take off. And therefore nowadays, there is a trend to do cataract surgery as well as an intravitreal injection at the same time. Patients with low immunity and patients who are allergic to iodine, which is a very, very good disinfectant, if they have low immunity or if they have iodine allergy, then maybe bilateral is not for them. We've talked about corneal decompensation, so patients with Fuchs endothelial dystrophy, for example. Lenticular abnormalities, pseudoexfoliation, subluxation of the lens, wobbly lens, and previous trauma, probably 1 eye at a time. Risk of glaucoma, so patients who have already had a trabeculectomy, bilateral trabeculectomy, for example, you go in there with phaco, there is a 1/5 chance of blocking up their functioning bleb. So probably in these cases, one eye at a time, and where there is a personal and family history of retinal detachment, or if they are really high myopes, and if they have a risk of biometry error, being short eyes, long eyes, and previous laser refractive surgery, and also patients with iritis. These are probably best avoided. Next, please. So here are examples of the not routine, unroutine cataracts. You see the exfoliation, really dense cataract, small pupil and dense cataract, requiring iris hooks, etc. So now, in terms of sterility, this slide will tell you how seriously we take sterility in Brighton at the Sussex Eye Hospital. So they're completely separate operations. We will re-glove, re-scrub, re-gown, re-drape, and we always drape so that the lashes are out of the way. And then also the drape would stick here nicely as well, so that there's no communication between the eye and the nostrils, because that's where bugs are as well. We will use a different trolley of instruments, and for one of the two sets of instruments, one would have been held back from the previous week. So you know that's of proven sterility because you've already, from that sterilization batch, you've already operated on dozens of patients, and if there was a problem, then you already know that that's a bad batch. We will use implants of slightly different powers or different batch numbers, and anything entering the eye, and we will reduce the number of things entering the eye. Now, entering the eye, we have your irrigating solution, your ophthalmic visco elastic device, any intracameral anesthetic, intracameral antibiotic, etc. They will bear different batch numbers or have come from different manufacturers. Now, my practice actually nowadays is to use subconjunctival cefuroxime in one of the two eyes so as to not put the cefuroxime in the other eye. Next, please. Which eye to operate on first? Well, if you're a surgeon, you will ask, well, usually, of course, the one with more severe cataract, but if you have got extreme asymmetry so that the dense cataract is actually a little bit risky, but the other one is easier, you might do the easier one first, and you've completed that, and then you can do the slightly riskier one, and you give the patient a better chance of having both eyes completed. Next, please. Choice of anesthesia. GA is possible, but actually nowadays it's mostly topical and subtenons. Now these are to be avoided if you can. Sharp needle techniques and also intracameral anesthetic in both eyes. One eye is okay. Next. Here's a scleral tunnel wound, which adds a couple of minutes to the operation, but you can see that it's much longer and much more secure, both to physical trauma and also potential entry of bugs. So a scleral tunnel wound is stronger physically and also gives you a lower risk of endophthalmitis. Next, please. Let's have a look at the catastrophic complications of cataract surgery. Expulsive hemorrhage, when the whole contents of the eye come through your wound and mushroom out. Now that is very unlikely nowadays with keyhole surgery, because when the intraocular pressure goes up, the keyhole seals itself and then it tamponates it, and it cannot bleed or come out anymore. Bacterial and fungal endophthalmitis, we know that with antibiotics and good draping and sterilization, the risk of endophthalmitis is under 1 in 1,000. However, that's not to say that the risk of both eyes developing endophthalmitis will be 1 in 1,000,000, and I'll explain why later on. It's because of this concept of conditional probability that the two eyes are actually not independent. So if one eye develops one particular complication, the other eye, because it's come from the same person and it's being operated on the same day, the other eye is likely to develop the same complication as well. So we don't really know how big the risk is of bilateral endophthalmitis. And it's the same for cystoid macular edema as well. You can do perfect surgery and you can still have cystoid macular edema. We'll go into that a little bit more in a moment. So my current surgical practice is, once we've discussed and had informed consent, then the first eye will be done under topical and intracameral anesthesia through a clear temporal corneal wound, and then have intracameral cefuroxime for protection from endophthalmitis. And then they wear a clear shield day and night for 1 week to stop them touching the eye. And for the second eye, they will receive subtenons anesthesia, because patients always feel the second eye more than the first eye, whether they're done on the same day or separate days. It's always like that. And I have this theory that when they first come for the first eye, they have no idea what's going to hit them. So they're really, really well prepared, and it's less than what they expect. So they think, oh, it's a doddle. So the second time round, they think it's a doddle, and then they feel everything, every single bit. So if you give them a subtenons, it's kinder to them because they don't feel quite so much for the second eye. I will use a scleral tunnel, and I will use subconjunctival cefuroxime mixed with dexamethasone and lidocaine as well to take away all the discomfort. And that eye will be padded till the following day, but they will see through the first eye, through the clear shield, till the following day. Next, please. Any questions on precautions?
Would tamulosine be a contraindication to doing 2 eyes at once?
Okay,
Because of
you're
the
asking me an
slowly-
advanced level question. I'm just talking about GCSEs for the moment.
But
However,
are there any drug
No, I tell
that's
you-
one drug, but are there any other drugs that would make you decide
Okay,
not to
no,
do
I-
bilateral?
myself, I'm not too worried because I will use intracameral phenylephrine to combat the possible floppy iris syndrome. And if it's really bad, then I just won't do the other eye. So it kind of depends on how confident you are and how good you are. As you get better and better, and the hospital is really good, you can actually will lower your safety threshold because you know under your hands it will be safe. So I'm happy to try. I will say to the patient, if this is really what you want, I mean, it's not that I would particularly recommend it, but if you really want it, I will do it for you. But if the first one doesn't go completely well, then we will not go ahead with the second one. So,
When you're doing bilateral surgery, is it done, the amount of general anesthesia which is used on operation is quite small amount, isn't it?
nowadays,
Compared to
very
topical.
small.
Topical
Yeah.
is
First eye
mainly-
topical, second eye subtenons.
Yeah, but most patients have topical, whether it's unilateral cataract surgery or bilateral. Is bilateral also topical, or is it general anesthesia given more?
No, we don't really use general anesthesia
No,
very much with bilateral. Not because if they would have a general anesthesia, not because it's bilateral, it's because they're very anxious or they're claustrophobic. And if it's local, then the first one will be topical. The second eye will be subtenons, so that they feel less. Okay, let's carry on. Now, this is actually a very short section. Stakeholders' perspectives. These are the stakeholders, and that may not be complete. Patients and their carers, surgeons, optoms, ward nurses, theatre nurses, hospital and trust commissioners, the healthcare economy, society in general, and sustainability. So we will just look at the first three in a tiny little bit of detail, and then the rest we will cover in the final section of the talk. Right. Patient. Pros: simplified journey, rapid and full visual rehabilitation. Undoubtedly. And people who have been through this, they are very happy. How about the cons? Well, they are taking a risk with both eyes at the same sitting, and bilateral recovery may be more arduous, especially if bilateral cystoid macular edema happen, and of course they will happen probably around the same time in both eyes as well, and they will have to go through a period whilst the cystoid macular edema recovers under treatment. They will also have a fear of bilateral blindness, of course. So it's really important that they go in with open eyes, that they have had informed consent, and they understand everything. Next. So surgeons and optometrists, well, the pros, and you are providing, if you believe in this, the best care for patients. And I think there is evidence to say that this is the best care. And if you do this carefully, it will enhance your reputation. However, if something goes drastically wrong, then you have a reputational risk. So you do need to bear this in consideration, bear this in mind. And of course, you also have a fear of bilateral blindness happening to your patients. Next, please. So any questions on stakeholders' perspectives? Have I lost something?
Just, if we were a group of hospital managers, we probably would go, we can save loads of money, and then presumably be putting pressure on the surgeons in our local eye department to say, hey, this is a great idea, we can do bilateral surgery, we can save X amount of money, and
You're absolutely right.
the surgeons will be going,
Yeah.
Just wondering how that dynamics.
I think that's why we have to be very careful, and that's why when I say, when I declared my interest, I didn't just say I'm a proponent of bilateral cataract surgery. I also said that I'm, careful and informed, and that's really important. You know that when people come up with really, really thick documents, most people just read the executive summary or even a summary of the executive summary. So the messaging has to be clear that it is not for everybody. Not everybody in every hospital can do it, and it's certainly not for every patient. And you will see we're going to go into this in much more detail in the ethical part of it, which is the final part in a moment. So,
is corneal decompensation almost a certainty with Fuchs dystrophy?
not at all.
Not necessarily.
Not at all.
Yeah.
I know that, and I'm a reasonable surgeon. Well, actually, I'm all right. That I have never decompensated a Fuchs patient.
Yeah.
Because there are precautions that you can do. So a scleral tunnel wound, which is further away from the cornea, and using a dispersive viscoelastic device like HPMC,
Yes.
using low phaco energy, and just being very careful with the maneuver. So it's very unlikely.
Good.
However, now we are actually doing corneal transplantation for Fuchs's dystrophy a lot earlier. And why is that then? Because we know that even with mild corneal edema, before they really decompensate, with those guttata, the excrescences, the contrast sensitivity for the eye after cataract surgery is not that great. So nowadays we're doing combined DMEC and phaco, even at a relatively early stage of Fuchs, because we know that gives them much better vision, especially in low contrast situations.
Right.
Yeah.
Okay. Thank you.
Any other questions? Okay. Well, let's have a look at the ethical and medical legal aspects of this practice. It is a relatively long section of about 10 minutes. Hopefully I will not lose too many of you. We know about the advantages, they're well rehearsed, and the strategies we just discussed. Next. Now, encouraged by people, I organized an ethical workshop in London, which took place on the 8th of June. And yesterday, I managed to upload part 2 onto YouTube. So you can watch that if you want, but somehow I have not managed to do the first half, which is the 2-hour part. So all in all, we sat there for 3.5 hours. After 2 hours, we took a tea break. And look at the people that we've had. 30 people, 3 ethicists, religious persons from the major religions of the land, 2 lawyers, 1 health economist, the chair of NICE Guidance, who happens to be the current president of the Royal College of Ophthalmologists, college officers, surgeons for and against, 1 optometrist sent by the College of Optometrists, and a number of patients who have bilateral and unilateral cataract surgery in one lay person. Next, please. So I've distilled the essence of all that into the next 10 or so slides. So let me try not to lose you, okay? Patient choice is really important, and it is said that bilateral surgery should or must be considered, and if the patient is not suitable, then you can dismiss it, but it ought to be offered to suitable patients. So even if you personally don't believe in this as a surgeon or as an optom, it should be discussed, and if the patient wants it, then if you don't want to do it yourself, you should send the patient to somebody else who can do this. Next, please. Consent, a very difficult issue. And as you know, consent really starts from the patient being referred and the consultation and the letter, the clinic letter you dictate, hopefully in front of them, and they get a copy of it, and then a consent form. But actually, most lawyers will say that consent form by itself is just a piece of paper. It doesn't really hold up to the law. And one of the two lawyers there said, well, maybe we can develop an app which takes them through everything, and then finally it's certified that they've really understood. Next, please. Bilateral cataract surgery can be done because there is already a substantial number of people doing it, and not only in this country, but also in parts of Spain, in Scandinavia, and other countries. So it is an established practice. However, you have to make sure that you don't put one step wrong, and all your documentation has to be perfect. Because if something should go wrong, the lawyers will ask you a lot of questions, and you should be able to answer them. Next, please. No surgeon can be forced to perform any surgery that they don't want to do. However, it is their responsibility to discuss all options, including bilateral surgery. Next, please. We, as doctors, the direct responsibility is to the patient in front of us, but we also have a duty, a higher duty to society to conserve resources. There's only a limited amount of money to go around, but if you save money by doing bilateral, then don't expect the money to appear back in ophthalmology or your department. It will be spent on some of the things like pediatrics or cancer or whatever. Next, please. The priest sent by Vincent Nichols, who is the highest Catholic person in the land, explained to us in the Catholic faith that we should give preference to the poor and helpless, and this includes conserving funds, because the poor and the helpless are the first to suffer when services go down to a lower level. Next, please. Think of the carbon footprint of doing everything one after the other when it can be all done in one go. People have been worried about creating two queues. We already have a problem not being able to do the first eyes of patients. How can we morally justify giving people a faster queue to get both eyes done when there are people not having had the first eye done? So it goes like that. They're actually two separate queues. So what you do is, because you can actually fit fewer patients onto each operating list, but more eyes per operating list. So initially, you will have a longer waiting list. But once that hump is over, people are not coming back for their second eyes quite so much, and therefore your queue will actually shorten. So it's a good thing. People have also been worried that trainees will not have second eyes to operate on, because obviously when you're doing both eyes at the same time, you say, got to be a senior surgeon, consultant, etc. But actually that's not true. If a consultant or a really senior person otherwise has done the first eye successfully, the second eye can be done by a trainee. There's no reason why not. Ward nurses are quite happy because instead of processing 6 or 7 patients for 6 or 7 eyes, they are processing 3 or 4 patients for 6 to 8 eyes. So they have less work to do on the ward. But in theatres, because of all the delicate balance of instruments and so on, the theatre nurses really hate this because they have to spend so much more time preparing the instruments. However, if bilateral surgery should become mainstream, then the manufacturers will put together left eye packs and right eye packs, and you just pull them off from the shelves, and that will become a lot easier. We've talked about this already, the prerequisites. How safe does it have to be before it can be offered? The thing is, to demonstrate safety, you need to do a study which involves maybe 10 million cataract operations, because the risk of bilateral blindness is exceedingly rare. Therefore, the consensus in this meeting, in this ethical workshop, is that, well, it seems to be safe enough, so let's just tread cautiously and then modify our practice as years goes on when we gather more evidence one way or the other. We've talked about fear, and let's try not frighten ourselves and patients. And we've talked about this as well. After both eyes have been done, it is a more arduous time because both eyes are somewhat uncomfortable. And certainly, if they're so unlucky to develop bilateral cystoid macular edema, then there will be a period when they need to be supported because they will have poor vision for a small number of weeks. There's also a concern that we might be doing unnecessary second eye operations, because if the patient had been offered just one eye, and even though they might have a visually significant cataract in the other eye, they might say, oh, wacky, I'm all right for the moment, and I won't have this done yet. And it could be months or years, or they may never come back. So the worry by some surgeons is that we might be doing some unnecessary operations. So this is actually a risk, which we have to discuss with patients, and also make sure that they really are bilaterally visually significant before we offer bilateral surgery. Uncertainties. Well, I've explained the conditional concept of conditional probability. Well, we don't really know what the risk is. We know statistically it probably is about 1 in 250,000, but it may be 1 in a million. But for any particular individual patient, we don't know what their individual risk is. So it has to be discussed with the patient that we don't really know what the risk is for you. Statistically, it's very, very small. So any questions?
What's the chances of, if the biometric measurements were not were an error,
Yeah.
what's the chances of a person developing mesometropia? Suppose he was long-sighted in both eyes pre-op, and post-op he became short-sighted in one eye and long-sighted in the other.
Okay.
And then
Well,
the problems in mesometropia, what's the problem
Yeah.
going to be?
I think biometry error is not very likely nowadays. And also, if there is a biometry error in one eye, which, for example, if they were +5, and then you got it wrong, then both eyes are likely to be either +1 or -1 together. I don't think it's likely that one will become -1 and the other still +2. It's just very unlikely. And also when you
What
have...
could cause that if that was the case?
If that was the case, then you have the same things that you can do, either glasses, contact lenses, piggyback implants, laser refractive surgery, or exchange of implant. Those are the possibilities, but very unlikely.
The patient may say that, oh, look, there was an error made, either in biometric or surgeon's error, to induce this anisometropia.
Okay, well, firstly, it's very unlikely that an anisometropia would be induced, but it's down to your having communicated with the patient through your discussions and informed consent.
Yeah, but can that happen, and should the patient pre-op should have been made aware that this is a possibility that can happen, that you can become short-sighted in one eye and you were long-sighted in both eyes?
Well, the problem is when you come to informed consent, if you want to discuss all the possible things that can go right or go wrong, it's going to take you a long time.
Yeah, right.
Now, it's not to say that you shouldn't do that, but I think in practice, we can't actually do that. So that's why we give patient information leaflets to help them understand things. and also communication and trust is really important.
Yeah.
That you need to show that you really care for them, because we do, but they also need to understand that we do have the best interest in heart.
Yeah, because obviously with the promotion of litigation, etc., on television, people, when they find that they were long-sighted, will become short-sighted in one eye and long-sighted. So they raise legal issues, don't they? They can and say, look, I should get compensation and
In
how do I
practice-
help with this?
In practice, whether optometry or ophthalmology, every second that we have a dealing with a patient, we are at risk.
Yeah.
That, this is no different.
Okay.
Any other questions? So,
So is a high refractive error an indication for bilateral sequential surgery?
well, it is and it isn't. It is because if you're doing one, you are bound to cause anastometropia. But on the other hand, if you have a high myope, when the biometry error can be high, and also there's a risk of retinal detachments, then maybe not. So it's a balance. And the thing about retinal detachment is actually not everybody believes that cataract surgery can precipitate a retinal detachment. And even if it does, it could be months or years later. So what do? You do one and wait a few years? It's just not possible. So it's balance. It's a real life situation, not black and white. Looks. So
Would your main concern be the effects of bilateral cystomacular edema post-surgery in this sort of procedures, given that it's a lot more common than endophthalmitis?
you're absolutely right. I think, of course, everybody is worried about bilateral endophthalmitis, but it's going to be very rare if you follow the protocol and you do things very, very carefully. However, if it does happen, it can be absolutely awful, isn't it? On the other hand, with bilateral cystoid macular edema, it's not guaranteed that they will actually recover their full vision, because some CMO do not fully recover or can go on forever. So yes, you're right. One is absolutely devastating and rarer. The other is likely to be a little bit more common. So also I'm worried about it because it's going to be more common than the other one, but it's not going to be as devastating as the other one when both eyes go dark. So
Patient with +5 right and left pre-op, and one eye's got cataract, the other one has no visually significant cataract. Would you still be justified in going ahead on the basis of they're going to be anisotropic if you do one?
I think that's an ethical question, isn't it? You're right. I think I would offer it, because based on the fact that this patient has a cataract, am I going to make him +5? Now, if he's accepting of that, that's fine. But if he really wants 0, I can give that to him, but I would be committing him to second eye surgery unless he can wear a contact lens. Again, it's a matter of discussion. And nowadays, it's not as though nobody does clear lens extraction, in middle age to help people with presbyopia. So if you were to ask me that question 30 years ago, it would be a different answer. But now it's kind of normalized. Refractive lens surgery has been normalized. The other thing about the +5 is that there will be a very low risk of retinal detachment in a high hyperope, and also there may be some problems with very narrow anterior chambers as well, and some pressure problem or risk of angle closure. So that that kind of makes it more ethical. Any other questions? So if not, then I will make some announcements. Yours truly is going to be engaged in the great debate at the Royal College of Ophthalmologists right here in Glasgow again on the 22nd of May. So please come and support me. This is going to be available. Part 2 is already loaded. Part 1 I'll try and upload this evening. You can go and watch that. If you want to watch 3.5 hours, okay, you can watch that. Make sure you've got your Coke and popcorn. And the Brighton cornea course, registration is open, and it's a very rare course that Eye News has just tweeted on my behalf. So obviously, I have great support from my family, and I just want to show you a photo of them when I was at Buckingham Palace getting my OBE. So when I get my knighthood, then I will invite you back. Next, please. So if you have any questions, or you can't find somebody to do your bilateral patients, you don't want to do it yourself, you do nobody to refer to, then I'm here as well. Thank you.
Thank you very much. It was a really interesting talk. It reminds me a lot of some of the processes we've been through with intravitreal injections. We started off draping up and taking patients to theatre, and then after the injection, looking with an indirect and checking the central artery. And now it's sort of, we're getting patients in, we're doing sequential intravitreal injections. But even more recently, we were giving topical antibiotic drops after the injections for quite a while. And none of us actually thought it was doing any good, but nobody wanted to be the first person because there was fear that was stopping us from doing something which we all believed in.
But I think nowadays it's just one drop of chloro and then no more post-op drops.
Yeah. So it's sort of, but it's taken time, and there was a gap. Even though people thought it was acceptable, it takes somebody like you, I think, to actually say, actually, I'm going to start doing it. I'm going to put my head above the parapet and do it. Can I just ask very quickly into the audience, who amongst this crowd, having listened now to that talk, would be happy to refer a patient if they thought they were appropriate for bilateral sequential surgery?
I'm not sure it's that straightforward, because surely it would depend on our local ophthalmologists and what data.
Just in terms of you, in terms of your own feelings. So it seems like just from the show of hands that there's sort of a positive idea about that.
Well, I mean, I don't know, because we didn't ask the question before my talk. But I can, if I ask a supplementary question, has the talk been useful?
Yes.
Thank you. Thank you.
Thank you very much, Edward.